Are you ready for the show? Okay, so we are quite pleased to share with you today some current progress on digital technologies in Parkinson's disease. Just to briefly introduce yourself, so Katarina is currently a DPhil student in clinical neurosciences, and I'm a postdoctoral researcher in digital health. We both work at OPDC with Michel, where we try to develop new digital approaches in Parkinson's disease. Okay, so the real question, why smartphones? I would like to do just a slight reminder on why we use smartphones today at OPDC and why they are relevant in our digital practice. I will try to speed up this part because Thiago already did a quite good summary on that. So if we just get back at the clinical level, at least in clinical research, what we can say is as soon as we want to measure severity of motor symptoms in PD, a common way, a widely accepted way to do it is by using the MDS-UPDRS part 3. And in fact, during this exam, what happens is as a patient, you have to perform several motor tasks. And for each of these tasks, what happens is you get a score for the given task. And this score is scaled on a severity scale. And after that, the total score gives you a general motor score. And we know that in clinical practice, there are some limitations with this kind of approach today. As Thiago said, for instance, we only get a snapshot of the motor symptoms at a given time in clinical practice. Another limitation is we don't have, the test itself is objective, but the way we score patients can depend on the clinician. So there's some variability with that. And this is why digital technologies like the smartphone can be interesting for that. The idea here is to get more frequent and more objective data on motor activity. So what we did is these last years at OPDC and with New Health now, we implemented a smartphone app for motor assessment. And this app is currently made of 7 tasks. And the idea is for each of these tasks, we automatically collect thousands of features regarding the motor activity of the smartphone user. And this is quite interesting because we can now have thousands of features on motor activities that are completely objective, and we can try to use it for clinical research. The thing is, with thousands of features, in fact, the rapid question we ask is, how can we analyze all these features together? And this is where machine learning can be quite interesting. In short, just to give a summary of machine learning and supervised machine learning in particular, what we can do is, as soon as we have a clinical variable of interest, like for instance the general motor assessment score, what we can do is we can work with algorithm to train our model to learn how to reproduce the clinical score based on the smartphone features. And one advantage of this approach is you can quickly have a versatile approach. If you have several variables of interest you want to reproduce, you can duplicate this approach each time using the smartphone data. So what we want to do with Katarina is just to show you a few illustrations of scenarios in machine learning with smartphone technologies we are currently doing at OPDC. And I will start with predicting fast versus slow progressor. So here, the motivation is quite simple. We know that there is high variability in PD motor progression across patients, And one consequence is it can be difficult for the clinician to anticipate in clinical practice how the motor progression will be for the patient, especially at an early stage. And so what we did regarding this, this idea of predicting fast versus slow motor progressor is we worked with, we tested an exploratory approach on a data set made of 98 participants followed during 96 weeks. And the idea here was quite simple. Each of these patients, they did their clinical assessment over 96 weeks, every 6 months. And during each in-clinic visit, what they did also is, in addition to the traditional clinical assessment, they also did the smartphone assessment. And in addition, we asked them to, when they go back home, during 1 week after the visit, to continue using the smartphone app and to do the smartphone test 3 times a day during the following week. And here the main concept to understand is this idea of fast versus slow motor progressor. What happens is, in this cohort, we had 2 subpopulations, and you can see on this graph they are completely different from each other if you look at the how the MDS UPDRS-3 score evolves in time. The fast progressor population, they are the black curve, and you can see that already at baseline they have higher motor impairment. And then when you look over time, you can see that this fast progressor group, they progress much faster regarding motor complication, while the slower group remain more stable. And the idea we had was quite simple, is given we can already see that with the clinical score, can we try to predict already at baseline how patients will evolve at 96 weeks, just based on the data from the first visit. And this is where we use machine learning. So here, I'm just, because for this study we did multiple things, and here I'm just focusing on the objective of prediction with smartphone. And we tested 5 different scenarios. And this scenario, they try, for instance, for the dataset preparation, we decided to train a first machine learning algorithm to predict motor progression just based on the MDS UPDRS-3 score. And this is what we call our clinical benchmark. And what we want to do now with smartphone is to get better results than this model. So we trained 4 other models. The second one was also a model to predict fast versus slow progressor, but this time we only used the result from the smartphone assessment in clinic. We then we repeated the same, but this time for the third model, we added the at-home data to see if there is some added value and some feasibility in using this data in this project. And lastly, we also tried 2 alternatives. This is what we call multimodal data set. In this case, we just mix both smartphone results with the clinical results to see if using these 2 models, these 2 data sets together, we can get better prediction results. And the results were quite interesting there. If you look the table on the left, so what we use, in fact, to measure the performance of our models is, Tanya already introduced that previously, it's the AUC. So as she said, when your AUC for your model is 0, it means your model is completely wrong. It is not able to do even one correct prediction. And when you look at the AUC, and if it's 1, it means your model is perfect, it's always correct to predict if a patient will become a fast or a slow progressor. And when it's in the middle at 0.5, it just means it's completely random. So what you want in practice is to be at least as good at least better than 0.5. And when you look at just the clinical score, you're at 0.53. So it's near random prediction. But as soon as you start introducing smartphone data, you can see the prediction improve. And something interesting also regarding the features that are selected by the model to do the prediction, most of them were from rest tremor, followed by gait and postural tremor. And the thing interesting is rest tremor and the postural tremor, they are both bilateral tasks. So we have data for both. And the gait is, there are already many studies that already showed a link between motor complication and gait impairment. So for this last minute, the thing interesting with this study, the short message is just with this smartphone app, we were able to improve prediction of motor progression at baseline in our cohort. And this opens quite interesting perspectives. For instance, we can think on a clinical level, at a clinical level, about the ability to monitor Parkinson's disease better. But in clinical research, it also opened the opportunity to more precise trial design where we can better stratify population at the start of study. And now I let you.
Thanks, Timothy. So I'm going to be talking today about another project involving machine learning and the smartphone data, which is predicting brain dopamine levels. So clinically, we can measure dopamine levels using a DAT scan, and perhaps some of you in the audience have had a DAT scan through the NHS at some point. And these scans are mainly used to distinguish between Parkinson's disease and lookalike conditions, so mainly in a diagnostic capacity, but now they're also being increasingly used as entry points to clinical trials which are focused on slowing the progression of PD. There have also been studies looking at DAT scan results in patients with REM sleep behavior disorder, or RBD, and showing that these changes may already be visible at this stage. So clearly there could be benefit in measuring and understanding these changes, and perhaps using this information in terms of, for example, measuring progression. However, these scans are expensive, and it's not something that we can do on a regular basis. We also know that in the UK, patients can often wait for up to a year to have a DAT scan through the NHS. So, what sort of proxy can we use for DAT scans, which can be measured easily and on a more regular basis? Well, we know that there's a really strong relationship between dopamine levels and motor symptoms. Specifically, multiple previous studies have shown that more dopamine loss is very highly correlated with worse motor symptoms. And this dopamine loss is measured as a striatal binding ratio. So this is just a quantitative measure that is extracted from the DAT scan. And all of these studies show that in general, the motor symptoms that correlate best with dopamine levels are the slowness of movement, posture, and gait. So within the OPDC cohort, we've been collecting both the in-clinic motor measures like the MDS UPDRS Part 3, and also our digital motor measure using the OPDC smartphone. We've previously shown that the data from the smartphone can be used to distinguish between groups and also monitor symptoms in Parkinson's disease. So in this study, we looked at whether we could use this data, so the in-clinic data and the smartphone data, to predict the outcome of these DAT scans. So in terms of the study pipeline, we collated all the data from the OPDC cohort. So this is patients with Parkinson's disease, patients with RBD, and also healthy controls, who had had a smartphone assessment, an in-clinic assessment, and also a DAT scan within a given time period, and we ended up with about 100 DAT scans. And we had two main aims here that we wanted to explore. So firstly, can we predict which patients had an abnormal DAT scan? And secondly, can we predict this actual quantitative measure, this striatal binding ratio, using the smartphone data, the MDS-UPDRS3, or combining them, so the clinical and the digital together? So first off, let's consider whether we can predict abnormal DAT scans in these patients. So I want to focus on the three bars in the middle, out of the interest of time. So here on the y-axis, you can see the AUC, which Timothy and Tanya have already explained. And this is the results when we use just the smartphone features, and this is using the MDS-UPDRS Part 3. So we can see that these perform very similarly, and they perform quite well with a AUC of about 0.85. Now what's interesting is when we combine the smartphone data with the in-clinic measure, this actually performs best in this data set. So we have an AUC of 0.88 when we combine these measures together. So given these promising results, what happens when we try to actually take this a step further and predict the actual striatal binding ratios in different regions of the brain that we're interested in? So here we have the results of just that. So each of these colored line plots represent the performance of a machine learning model in predicting a different region of the brain that we're interested in. So this is the right and left caudate and putamen, respectively. And our first result here is what we call the naive benchmark, and that's essentially what we're trying to beat with our models. And the y-axis here is the error, so the lower the better. Now we can see that in general, when using the MDS-UPDRS3 alone, it performs better than using the smartphone features alone. But what's quite interesting here is that when we combine these digital and clinical measures together, we get the best performance overall in all four regions of the brain that we're interested in. So why does this matter, or why are we interested in doing this? So we've shown that in general the smartphone test can predict DAT abnormality just as well as the MDS-UPDRS3. And we've shown that we can predict dopaminergic deficit when using the clinical and the digital measures together. What we'd be interested in doing now is testing this in a larger data set to make sure that it generalizes well. And the idea behind this is to, one, help us decide which patients need a DAT scan first, and also secondly, to pre-screen which patients are likely to qualify for clinical trials. In the future, we see this also being combined with other measures to help us predict progression in Parkinson's disease and also phenoconversion. Given that this would be low cost and available to all, we think this is a promising result from this study. Just going to take 30 seconds to talk about the next steps in the smartphone work that Timothy and I are doing. So firstly, the next step is to look at building a composite digital motor score. So we want something that's interpretable and a smartphone-based score which we can use to track motor progression in PD. And that also brings us to our next point, which is to do this, we would also like to expand the amount of healthy control data that we have, so increase the number of healthy controls so that we can better separate patients with Parkinson's disease from control subjects. Thank you.